enormously. But thank you very much for asking me to join this.
Definitely, these have been trying times, but we are very grateful that you have been able to join us through Zoom. So, without further ado, let's start off by talking about the topic for today, which is the impact of predisposing factors for CHDs. So, Dr. Qureshi, what is the correlation between consanguineous marriages and congenital heart diseases? And how does this affect the management of a patient with congenital heart disease?
That's quite an important subject, really, especially for Asia, but many other countries in the Middle East as well as Far East. Consanguinity is part of the culture, and so the impact of it is not discussed too often. The issue related to consanguinity is the fact that congenital heart disease, when it occurs, can be complex. And I'll come back to that. There are several papers in the literature from different parts of Middle East, such as Lebanon and Saudi Arabia, and also Indonesia and a few others, which have shown that in consanguineous marriages, babies are slightly increased risk of being born with complex heart defects. So whereas in the general population, the incidence is around 1%, in consanguineous marriages, it's double that almost. So that's one of the risks of being born with congenital heart disease. Consanguineous marriages are also associated with other congenital defects, non-cardiac, so all sorts of other complex defects as well. But as far as the heart is concerned, there are certain defects such as ventricular septal defects, atrioventricular septal defects, tetralogy fallow. These are more likely to occur in babies of consanguineous marriages, but in particular, the very complex circulations which eventually result in single ventricle circulation, hypoplastic left heart syndrome, other tricuspid atresia and other defects, they are more like atrial isomerism, which is a particular form associated with heart defects. They are particularly more likely to occur in cousin marriages. And that's why it's important to emphasize this issue. Excuse me. The complex heart defects tend to be more difficult to manage after birth. They're then associated with not one operation, but can be a series of operations to get somewhere near a normal circulation. And then there is more likely a need for future interventions. So it's an ongoing burden on the family to have to deal with this sort of heart defect. There are some heart defects like hypoplastic left heart syndrome, which back in the 80s and 90s in the UK, we didn't offer any surgery. And so these babies were allowed to take a natural course, and majority of them died. And it was really in the mid-90s that we started doing surgery on these defects. It then means, of course, that there's a series of operations that are required to achieve some sort of circulation. So in countries like Pakistan, unless you provide free health care on an ongoing basis, this can become a huge burden for the families to have multiple operations, multiple catheter interventions, and so on. So it does need a lot of thinking about how to deal with these particular defects. There was a study done by Masood Sadiq when he was in the UK in the mid-90s, and it was published in the literature. And at that time, he was training at Birmingham, which looked at congenital heart disease in the non-white population, and it was associated with, firstly, increased incidence, and secondly, more complex defects. And so consanguineous marriages has a huge impact on the families. Firstly, because there's an increased incidence of complex heart defects, and secondly, because those complex heart defects then require pretty much ongoing series of operations and then lifelong follow-up.
So when we talk about the management of a patient from a consanguineous marriage, is there a difference in the treatment protocol between the West and LMICs such as Pakistan, like for example, in terms of counseling or during the treatment process or anything?
In some ways, yes, because what we have in the US, UK, and Europe and developed countries is a fairly well organized program of fetal echocardiography, so prenatal detection of complex heart defects. And then that allows the families to plan, either expect a problem immediately after birth, or in some cases, a therapeutic abortion, which raises a different set of moral issues in countries like Pakistan. But certainly it allows the parents to make an informed decision about whether to proceed with pregnancy, and also whether they will accept ongoing series of operations. So, excuse me. So it does raise a lot of issues. And so fetal echocardiography is an area that is probably under organized in countries like Pakistan, and it's an area that probably does need a bit more focus, because that then allows you to plan the management after birth a lot better. Then obviously we have a lot of discussions in the West with the families as to whether they're prepared to have multiple series of operations, all with high risks. And so the families then make an informed decision about whether to proceed or not. And that's why it's an area that really does need emphasizing, does need a lot of discussion on a national basis and at professional basis, as well as with families.
So you mentioned the role and importance of fetal echocardiography, especially in relevance to LMICs. So could you please elaborate a bit more on that? At what period of gestation is it important to have your fetal echocardiograph, and the role and involvement of the cardiologist during this entire process? And you mentioned therapeutic abortions as well. So what are the indications which would lead to a decision for this treatment process?
Yeah, so again, very good question. So we do fetal echocardiography around 18 weeks into the pregnancy. 16 weeks is fine as well. And there are some centers which it requires a bit different technology, but can do it at 12 weeks. But certainly around 16 to 22 weeks of gestation, echocardiograms in the fetus are performed. Majority of the defects can be picked up. In fact, the detection rate can be up to 70%. In order to achieve the maximum effect, you have to train obstetric sonographers in some basic scanning, and then after that, when they suspect a heart defect, the pediatric cardiologist, fetal cardiologists then have an important role in the diagnosis. And once that is done, then the parents can be informed of the possibility of the type of heart defect. And there are complex defects like hypoplastic left heart syndrome, isomerism, left or right atrial isomerism, which are associated with a huge series of heart defects, that we can then talk to the parents and say, look, there is either nothing that we can do, or if we can do anything post-operatively, it's going to need 3, 4, 5 operations, and all of them may carry risks of 30 to 40% initially, and then slightly less. So the parents can then make an informed decision about whether to have a therapeutic abortion or not.
Okay. So now moving on, let's move on to afterbirth and interventions and catheterizations, treatment processes after the delivery of a baby. So could you please discuss the differences in interventions in babies or neonates compared with that of surgeries?
So there are some heart defects which can only be dealt with by surgery immediately after birth. There are some heart defects which can be dealt with purely by interventions, catheter interventions, and there are some heart defects which require a combination of the two. So as an example, transposition of the great arteries, for example, if you detect that, that is going to need an arterial switch operation, and that's preceded by occasionally by balloon atrial septostomy. So, but the majority of treatment is required, is going to be surgical. There are some defects where Blalock Taussig shunt is required in order to allow the baby to grow to beyond 6 months or a year before undergoing surgical correction. So defects like tetralogy of Fallot, for example, or pulmonary atresia. And then there are some defects where a combination of the two is required. So for example, hypoplastic left heart syndrome, we sometimes do a hybrid procedure where the surgeons do bands on the pulmonary arteries and we then put a stent in the duct. So it's a combination of the two that's required. But if I pick a relatively less complex heart defect like tetralogy of Fallot that presents in the first 2 to 3 weeks of life, and there the surgeons do Blalock Taussig shunts, but even now, after more than 60, 70 years of Blalock Taussig shunt surgery, the mortality from the data, both from UK, Europe, as well as USA, is that the Blalock Taussig shunts have a mortality of around 7 to 8%. And so in those situations, in those patients, if you pick the suitable ones, catheter intervention like stenting the right ventricular outflow tract or stenting the PDA may then become important and have an important role to play, because that avoids the initial Blalock shunt surgery, allows the baby to grow to an age where and weight where whatever surgical correction is required can be carried out. So, so the interventional methods have, in some cases, have an important role to play. So a lot of it is not a competitive approach between the surgeons and the cardiologists in the catheter lab. It's a collaborative, cooperative approach where one procedure helps the other operator at a later date. And that's the way we should look at it.
Definitely, because this is treatment of patients is always a collaborative and team effort. And if we apply this to LMICs, for example, how can this benefit patients in terms of readmissions or shorter hospital stay, post-operative recovery, and prognosis and life expectancy?
Okay, again, very good, interesting question. So there are some interventions which require only, even in newborn babies, 2 or 3 nights stay. For example, pulmonary stenosis, which is, if it's critical and duct dependent, balloon dilation can be done and the baby can be home within 2 to 3 days, 4 days at most. There are other interventions like in pulmonary atresia, intact ventricular septum, where we can do radiofrequency perforation and then possibly combined with duct stenting. Again, that shortens the hospital stay for those babies with fairly complex heart defects. And there are other heart defects where the combination is required, in which case they stay in hospital longer. So some interventions essentially result in shorter hospital stay. And if they're being charged, then obviously the cost becomes less compared with surgery. But there are other defects where the stay is going to be longer with combination of intervention and surgery being required. but that again depends on who is paying. Uh, Heart defects in children and the treatment of is of necessity going to be an expensive procedure, expensive to the hospital, expensive to the parents, and therefore expensive to the government. And so it depends on how well the funding is established. For example, in the UK, it is less of a problem because the National Health Service pays for everything, and so there is no cost burden on the families. So the cost burden is on the National Health Service and therefore the government. In Pakistan, it's likely to be required that it'll be a burden to the government, it'll be a burden to the hospital, the families, and therefore alternative solutions are going to be required, such as, and this is where I support PCHF. So charity organizations may have a very important role to play until such time, and that is a long way in the future, until such time as the government fully funds the treatment of babies and children with congenital heart disease.
Definitely, and PCHF was always very grateful to you for your support and your expertise and your guidance. So we were talking about safety and post-operative quality of life of children. So could you please comment on the safety and efficacy of stent redilatation in patients?
So when there are some defects where stents are required, for example, in patent arterial ducts in newborns, if you want to delay the subsequent surgical corrective treatment for 6 months to a year, then those stents may need to be redilated, and that can be done safely, but more often than not, a second stent may be required in order to achieve a good effect. Other lesions, such as branch pulmonary artery stenoses, aortic coarctations in slightly older children and teenagers, for example, if we put a stent in a growing child and that stent is going to stay there, then it will need to be redilated as the child grows. And so we have to have options available. Now, depending on where the stent is, it can be redilated, but there may be a small incidence of complications such as a tear in an artery or in the vessel on either side of the stent, and therefore you have to be prepared to put a covered stent in order to rescue the situation. So although stent redilation is safe, it does require other possible rescue solutions, such as another covered stent or more than one covered stent, in order to deal with any tears that may occur. But the older the child is, so for example, teenagers, you're only likely to require one redilation when the child is fully grown. If the child is less than 10 years and we're putting stents in, then those stents are going to require 2, maybe 3 redilations to achieve the full growth of to match the patient.
Okay, thank you. Of course, in your vast list of coveted achievements, we absolutely have to talk about the TISHAC balloon. So could you please kindly elaborate on the development of the TISHAC balloon and how it has facilitated in improving congenital heart disease outcomes?
Yeah, thank you. So in the mid to late 80s, when interventions started to progress, it started with coronary angioplasty. Then the radiologists started using balloons for different larger vessel dilations. And the balloons that were available, we were then trying to use them in babies and children, and they had a very large profile. So when we were using balloons for pulmonary valves even, or coarctations or aortic valves, the profile of the balloon was large to the extent that we had a lot of damaged femoral veins and femoral arteries. which then required treatment themselves. And so there was a need for producing a more specific balloon for babies. And that's how we worked on, my colleague Michael Tynan, who's retired now from Guy's Hospital. He and I worked on what was required, what sort of diameters and lengths and French profiles of the balloons was required for safer access in the femoral veins and arteries. And that's how Taishak balloon was developed by NewMed in the United States. And after the initial testing, we then felt that it was safe to use, and that became more widely available. And now it's used widely around the world. So you can put for example, up to an 8mm balloon through a 3 French and 4 French sheets. Taishak Mini, for example, can be passed through a 3 French sheet. So these balloons can be passed through smaller French sheets, and in babies, that's very important to protect their veins and arteries.
Wonderful. That definitely has changed the course of interventional cardiology. So what about its application in LMICs? Is it widely and readily available and easily accessible?
Oh, yes. It's certainly available and accessible. A lot of it depends on the countries having distributors, but as far as I know, it is available around the world. People are using it widely.
Wonderful. Okay, so now moving back to the UK, and speaking of safety, what has your experience been like as a cardiologist in dealing with COVID-19 in the UK?
So COVID-19 had a huge impact in when the first wave started. It resulted in the intensive care units being taken over by adult patients that required CPAPs and BiPAPs and then ventilation, which then meant that we had to cancel all or majority of our elective work on babies and children. And the only thing we could do was emergency cases. Of course, when we were doing emergency cases, then we had to have the full protective equipment, full masks and gowns and gloves and double gloves and so on. But it had a massive impact on the number of cases that we could do. Once things got under control, that restriction was lifted, and we were beginning to get back to more elective cases. But in the last week or two, well, the numbers have been increasing rapidly in the last 3 or 4 weeks, but it's only in the last week or so that we've gone into a second lockdown, which has meant that, again, we're restricting the pediatric elective cases and only dealing with emergency cases with the same precautions as previously.
You mentioned the second lockdown. So for the CHC patients who are waiting for things to improve and who are waiting for elective surgeries to resume, are there any words of advice or caution that you would like to extend to their parents and families who are worried that their children might not be able to get access to timely treatment? This definitely also applies to patients over here. So if you could please elaborate on that.
Yeah, so what we're doing is we go through the waiting list and identify those children in whom we can effectively wait, because their heart defects may not be so severe as to need emergency treatment or urgent treatment. So we identify those and say these can be deferred for 3 months, and by then we hope that there'll be better control on the COVID. Then there are some that can't wait for 3 months, and so we identify those and say, well, within the next 1 month or so, this particular child will need treatment. And so we then say to them that on a particular date that we've allocated to that patient, they will need to isolate for 2 weeks beforehand. And then 3 days beforehand, they would need to be tested for COVID and remain isolated until they come into hospital, and then have further testing for COVID before we then proceed with the whatever intervention is required or surgery is required. The surgical cases, again, similar approach is adopted. Identify those that cannot wait, and therefore try and isolate them for 2 weeks, do COVID testing, and then carry on with their treatment. So some work is being done. It doesn't mean that cases are cancelled completely. And of course, the final advice we give to the parents is that if they're worried about anything, any issues in relation to their child and their heart defect, they contact us, and then we can decide whether we should proceed or defer.
Definitely, and here's hoping that the situation improves soon globally. So learning from your experience in the UK, you mentioned charity institutions and the importance of their roles. So could you please expand on that with reference to the application to developing countries?
So I'm involved, for example, with Chain of Hope, which is a charity that was established back in the mid-90s. And we have a fairly sort of a wide series of aims. So in countries such as underdeveloped countries in Africa, where there may be no services available, if those countries want to develop, they contact us, and so we then send us teams out on a regular basis, and that can be depending on their local requirements. It can be once a year, twice a year, anything up to 6 times a year. Different teams are sent out, and those teams consist of a surgical team with surgeon, anesthetist, their assistant, and intensive care nurses, and catheter intervention teams, an operator with anesthetist and a catheter lab nurse and other nurses to help with recovery. And those teams can go for anywhere between 1 week and 2 weeks, do a series of cases. But the main aim is not just to go and do cases. The aim is to treat, not just treat the children, but also train the local teams. And that is, the local teams can be surgeons, anesthetists, perfusionists, intensive care nurses, catheter lab, doctors, nurses, anesthetists. So a wider team is trained. And then after a series of visits, we then allow the local teams to be the first operator, assisted by the visiting team. And then eventually we want to get to a stage where the local teams are sufficiently trained to be able to do the cases themselves without the visiting team's help. When that stage is reached, and we've got examples in a few places like that, where the Chain of Hope supplies them with consumables, because that's what's needed, and the local teams then carry out operations or interventions by themselves. And so it's a staged process, and Chain of Hope goes to many different countries in Africa as well as West Indies, and in other parts as well. And there are similar other charities in US, in Europe, and Asia and Middle East that do similar sort of work around the world. It's a very important piece of work. It's dealing with an unmet need in many of these countries, ultimately our aim should be and is that we make the local teams self-sufficient.
Definitely, that is a very important part of congenital heart disease management and global leadership, which charities can enforce throughout their work. So, PCHF also is involved in capacity building in Pakistan, and it follows a similar model that you have mentioned. So I think in terms of management of congenital heart diseases and LMICs, we are on the right track. It's about collaboration and moving forward, inshallah. So moving on, I recently heard your interview, your podcast from the Fresh Heart podcast, and it was absolutely so impactful for me on a very personal level and on a professional level as well. So could you please share some golden words from your journey as a leader in your field, particularly to help identify which aspects of pediatric cardiology to focus on for the future?
Well, the first thing I would like to emphasize is that if you are faced with challenges like I was, it may be that you, people in Pakistan, doctors, nurses may not face the same challenges, but if you are, then you really have to work out strategies to overcome those challenges. And if people either put you down and tell you that you're not very good in whatever you want to do, then that is the challenge that you must overcome and show not just those people, but the wider community that you can defeat any of these challenges and achieve whatever you want to do. The same thing happens not just in pediatric cardiology, but on a wider scale where people try and undermine you, and it's those things that you have to be aware of and overcome. In pediatric cardiology, apart from dealing with those challenges, we've got challenges in trying to achieve better standards, better results, better quality of care, a more comprehensive quality of care. And we should therefore really be looking at, as doctors, we should be looking at everything from the parents and the family's angle and see how well we can deal with the children and the families and support them to achieve a normal lifestyle, no matter how complex a heart defect is. And that's a bigger challenge. We often would be accused of not putting ourselves in the family's shoes and then looking at ourselves from the family's angles. That's something that is very often forgotten about. And I certainly try and maintain that approach and have done from very early on in my career.
Wonderful. Thank you for those insightful words. So in terms of professional growth, what would you advise future interventionists?
So the future interventionists, you've got to have a longer term view of things and not just accept that you're going to do some simple defects and be satisfied with those. You should really be looking at how you can do obtain experience in much wider range of interventions, and then provide that care back to the children and the patients. And that usually means that you need to have mentors available to you, that you can run things, ideas past them, ask them for advice, ask them for supervision, and be mentored until you get into a position where you can then mentor your younger colleagues. So it's a cycle, an ongoing cycle of life, isn't it? You plant a tree and allow the branches to grow, and then you plant another tree and allow other branches to grow, and and so on. And that's we should be worried less about ourselves, but more about the others and how we can support others and develop others and mentor others in order to for the people that go out to different hospitals can then spread their expertise much more widely.
Definitely, learning is a lifelong process, and I think the first step is, for example, coming from yourself as well, is to not be intimidated to approach your mentors, to ask them questions, to learn from them. I think that is a very amazing quality that I have found in you. It's the humility that all our mentors worldwide share.
Yeah, thank you. I mean, very quickly, if I could give you an example, around the world, and that can be, I'm not going to go through a list of countries, but people use FaceTime or WhatsApp video or whatever and say, and show me in the middle of a procedure that they're doing, show me the camera, the fluoro X-ray machines, echocardiograms, and say, we've got this problem. And then we sort of discuss the solution, and it's quite nice to see that the person is then able to complete the procedure whilst I'm sitting at home or in the office in front of a camera or computer. And what that is showing now, and it's all been forced by COVID, is that you don't need to travel in order to help a much bigger number of doctors and patients. And that's, again, a different form of mentoring to what people might understand in the normal sense.
Definitely. I myself have learned so much in such a short period of time. Even through this webinar, it has absolutely changed my perspective, my approach. So we are always grateful to our mentors. And speaking of mentors, Dr. Masood Sadiq has joined us. Assalamu alaikum, sir.
Walaikum assalam.
Yeah, sir, welcome. अगर आप कुछ share करना चाहें, please do.
No, I just wanted to first thank Professor Shakeel Qureshi. Probably you know that he's my mentor. Actually, he's mentor to so many people in this country. I think, in fact, we owe our interventional program in this country to Professor Shakeel Qureshi. And I think in that respect, I think the sort of respect he enjoys from interventional community all around the world, we know that. He was just mentioning about people doing procedure in the middle of the procedure, calling him and asking him questions and taking his advice. I have done it many times. I'm stuck in the middle of a case and I would call Shaq and ask him, and you would always sort of find that advice as most pertinent and most useful. I think one of the things he was mentioning about future interventionists and so on, I think what we learned from Shaq and some of the other people in this field is that an interventional pediatric cardiologist needs to be patient. And I think this patience somehow, I know this comes with age, it comes with how you are groomed and so on. What I find sometimes in my junior colleagues and the budding interventionists, and I would like Shaq to comment on that too as well, is that they tend to be impatient and they want to do things far more quickly. What we have learned from him is that you spend more time in planning, looking at things, organizing yourself, making sure everything is available, all the hardware and the stuff which needs to be or potentially would be used in that particular procedure is there. You view the echo, you view the CT, you view at the previous angio, you look at the child, examine yourself, and so on. So you make a comprehensive sort of picture first, and only then you proceed. And actually doing the procedure is the shortest shortest bit of the entire thing. What you really need to spend time on is decision making and then making sure that you know about the entire thing. And that I sometimes find lacking when people are relatively young and try to do things fairly quickly. And I think that will be the biggest message to our budding and new interventionalists, that please spend time on the patient, talk to the family, make sure you get all the data and all the relevant information first, plan it, and spend time on once you have done everything, and then actually do the procedure, because doing bit is actually the easier bit. It's the decision making, and whether you should do it or not is probably the most important thing. Thank you.
Just to reinforce that, that's an excellent point. Whenever somebody contacts me for advice on a particular type of procedure, I actually ask very basic, simple questions first before giving the advice, because I need to build up a picture in my mind about the patient. And then, like Masood said, the equipment has to be available. It's no good starting a procedure and then halfway through saying, well, I haven't got this piece of equipment, I'll have to use whatever I've got. That is not necessarily safe, and it's much better to plan things, because ultimately there's a life that you're dealing with, and you want to do a procedure safely without any risks to that patient. And that, if you improvise with equipment, you use something that you really shouldn't, then that's going to do more harm than good. So very important point about being patient, but going through everything in meticulous detail.
Definitely, patience is a virtue, professionally and of course personally as well. So when we talk about patience, could you please elaborate a bit more, Dr. Masood and Dr. Shakeel, how future interventionists, they can be patient with dealing with society-based challenges? For example, in terms of patient volume, in terms of patient education, patient awareness, especially here, when we're dealing with patients who do not adhere to some management protocols, such as maternal nutrition, just fetal echocardiography की भी बात हुई थी, they do not meet up with their antenatal visits. So ऐसे challenges को face करने के लिए, what is your advice?
Go on, Masood.
Sir, sir, I would let you answer first, sir.
The part of this is cultural problem, isn't it? So if the families do not adhere to whatever protocol or management advice you've given them, then that's a very difficult challenge. Funnily enough, if I can just briefly recount a story to you that I'm having to deal with next week. Another center in the UK has contacted me yesterday about a lady from Pakistan who's had double valve replacement and is pregnant, and she has refused to take warfarin and hasn't taken warfarin for the last 2-3 years since she moved from Pakistan. And the doctors there, they phoned me yesterday to have a chat with her on Monday, but the doctors are almost thinking of going to court to make her have warfarin treatment because she's refusing. And she's from parts of Pakistan that I'm not going to mention, but very stubborn. And the family is similar. And so there's not much in Pakistan. It'll be very difficult because they won't turn up to the doctors. But here, at least the doctors have got to, they can go to court and make the patient deal with this. It's a potential problem in different parts of Pakistan, not in cities, but in villages. And apart from if you have a parents or a patient support group that can, in this day of social media, if they set up support groups to provide that information, that is going to have a much bigger impact than doctors saying to patients, you must do this. In the UK, we've got very powerful parents and patient support groups who, when they started out in the mid to late 90s, just had a very small role, but now we use them for a lot of education, a lot of support for the patients and parents. And that is something that you may have to think about, because social media is getting stronger in everywhere now.
I think सर ने बहुत अच्छे तरीके से इसको एक्सप्लेन कर दिया, और ये जो सोशल और कल्चरल एस्पेक्ट को हाईलाइट किया. मेरी नज़र में एक बहुत इम्पोर्टेंट पॉइंट जो कि हम अक्सर ओवरलुक कर जाते हैं, बेसिकली पेशेंट डॉक्टर रिलेशनशिप है. और मैं समझता हूँ कि जहाँ पे हम थोड़ा सा एक्स्ट्रा टाइम इन्वेस्ट करते हैं और एक रेपो डेवलप कर लेते हैं फैमिली के साथ और उस पर्टिकुलर पेशेंट के साथ या उसकी फैमिली के साथ, वहाँ पे सक्सेस के चांसेस बढ़ जाते हैं. लेकिन प्रॉब्लम फिर वही आएगी डॉक्टर साहब जो आपने बात की, कि जहाँ वॉल्यूम्स बहुत बड़े होते हैं और अगर आप एक वक्त में बेशुमार मरीजों को देख रहे हैं, तो आपके पास वो एक्स्ट्रा टाइम नहीं है जिसमें आप वो रेपो डेवलप कर सकें फैमिली के साथ. तो उसमें फिर आपको हेल्प की ज़रूरत है, आपको सपोर्ट ग्रुप की ज़रूरत है, आपको किसी नर्स की ज़रूरत है, आपको किसी नर्स काउंसलर की ज़रूरत है, या आपके एरिया में जो आपका जनरल प्रैक्टिशनर है जो कि उनके साथ ज़्यादा इंटरेक्शन में होता है, उसको हम किस तरीके से इन्वॉल्व कर सकते हैं. तो वो फैक्टर्स इंपॉर्टेंट हो जाते हैं. मैंने ये देखा है कि जो पेशेंट्स जो उनको आप ओवर द इयर्स देख रहे होते हैं और जिनके साथ आपका एक सर्टेन रेपो डेवलप हुआ होता है, उनमें हमें इस तरह की प्रॉब्लम नहीं आती, और मोस्ट ऑफ द टाइम्स आप उनको कन्विंस करने में भी कामयाब हो जाते हैं, क्योंकि उनका भी आपके ऊपर एक ट्रस्ट का फैक्टर होता है और एक ट्रस्ट का लेवल होता है. लेकिन जहां आपका ये रिलेशनशिप डेवलप नहीं होता, वॉल्यूम्स बड़े हैं, रश ज्यादा है, बेशुमार मरीज हैं, और आपका पर्सनल उनके साथ रेपो डेवलप नहीं हुआ, वहां पे डेफिनेटली ये प्रॉब्लम आती है. और जैसे सर ने कहा कि बहुत सारी चीजें कल्चरल जरूर हैं. ऐसे ही है जैसे आपने भी देखा होगा, मैंने भी देखा होगा, आज भी मैं क्लिनिक पे सख्ती करता हूँ कि कोई बंदा मास्क के बगैर अंदर नहीं आएगा. तो कुछ लोग रेजिस्ट करते हैं, बल्कि बाज़ बार लड़ पड़ते हैं रिसेप्शनिस्ट के साथ. अंदर वो आ तो जाते हैं क्योंकि उनको पता है डॉक्टर साहब देखेंगे नहीं. आते ही सबसे पहले मास्क उतारते हैं और कहते हैं डॉक्टर साहब पहले दसो हैवी है या नहीं. अब वो दिस इज समथिंग विच आई थिंक इज कल्चरल, विच इज सोशल, जो आप सोशल मीडिया से, अपने कल्चर से, बाकी चीजों से, आपके घर के बड़े बाकी लोग किस तरीके से इस चीज को यूज कर रहे होते हैं, उससे आप लर्न करते हैं. तो आई थिंक इसमें पाकिस्तान में अभी तक इस तरह के पेशेंट सपोर्ट ग्रुप्स नहीं बने अक्सर जगह पे, और ना ही हमने नर्स काउंसलर के कॉन्सेप्ट को बहुत ज्यादा आगे बढ़ाया है. तो आई थिंक इस पे मैं समझता हूँ कि मे बी पाकिस्तान चिल्ड्रन हार्ट फाउंडेशन कैन टेक ए लीड. मैं फरहान से कहूँगा, बाकी लोगों से कहूँगा कि हम इस कॉन्सेप्ट को थोड़ा सा आगे लेके चलें, और कम से कम कंजेंटल हार्ट डिजीज के कॉन्टेक्स्ट में, जो कि हमारा फोकस है, हम अगर डिफरेंट एरियाज में इस तरह के पेशेंट सपोर्ट ग्रुप्स को इनकरेज करें लोगों को ज्वाइन करने का, और फिर कोई नर्स काउंसलर्स या कोई साइकोलॉजिस्ट या बाकी लोगों को इन्वॉल्व करें, तो आई थिंक इसमें हम सिग्निफिकेंट इन रूट्स कर सकते हैं.
हमारी तरफ से ये एक एफर्ट है, like for example Dr. Shakeel, he explained very nicely and elaborately about the role of consanguineous marriages in congenital heart diseases. So ये भी, this is also a very big societal challenge within Pakistan. So we hope through these webinars and through our expert speakers we are able to educate our public on the importance of predisposing factors in congenital heart diseases. We are running short of on time, so Dr. Shakeel, there are just two questions before we wind up. A question hai कि how long will a stent last after surgery? And the second part of that question is after a catheterization or stent procedure, when should I call the doctor, or what sign should I look in my child before I call the doctor?
So that's going to depend on the age at which stent is implanted. So if the stent is implanted in the first year of life, for example, then that stent is not going to last lifetime. Either it will need to be re-stretched or re-dilated, or at some stage it may be a stent that cannot be dilated too much, in which case it will have to be removed by surgery another time when the child is older. The second question was, again, if the stent is in the PDA or patent ductus or right ventricular outflow tract, then if there are any changes in the signs in the baby, for example, blueness that is increasing, or breathlessness that's increasing, then they should be evaluated by a pediatric cardiologist, because either the stent is becoming blocked or narrower and may need further intervention. So very important two questions there.
Thank you, sir. Thank you very much for answering all of today's questions and answers. Mr. Farhan Ahmed has joined us. Assalamu alaikum, sir. If you could please give in your 2 cents.